Neonatal examination. Start with read, intro, and consent, and explain with exposure. Then we will do start the neonate examination. The first step is inspection of the neonate. On inspection, we will check the neonate superficially, whether he is well, and whether there are any interventions like granula or any pigmentation or any bruise or any scar, any injury or any dysmorphic features like cleft lip or palate. Then we will do anthropometry, but prefer to do it at last, and in which we check height, weight, head circumference, and mid upper arm circumference. Number 3. Now we will start the examination. In the examination, we will look at the nails and we will check for any signs of clubbing, Koilonychia, splinter, Lyconychia, anything, peripheral cyanosis, count fingers and toes, whether they are 10 or more, 20 or more. Check for palms for any visible deformity, simian crease of Down syndrome. Check the wrist for whether there is any wide wrist or any deformity. Now check the head and feel the head. No, before that, palpate the axial lymph nodes and then check head for feel the sutures. Feel the anterior fontanelle in which you feel size, its shape. Size mostly is average 2.5 to 2.5 centimeter. Shape is mostly rhomboid, and feel it whether it is dense, flat, bulging, or rigid. Then check for caput hematoma or cephal hematoma. Caput hematoma in SVD and cephal hematoma in instrumental delivery, and visible injuries on the head. And check for hairline whether it is low for Turner syndrome. And then check the eyes for any subconjunctival hemorrhage or any brush field spots or any cataract or any visible deformity. Then I check the nose from check the bridge, and where torch check inside the septum, inside for septum boils discharge. Check the mouth with torch to check whether there are any teeth or neonatal teeth or whether there is any deformity inside the mouth. Check the ears whether there are any skin tags, whether there are any injury due to instrumental or any other thing, whether there is whether they are low set as in Down syndrome, whether, and then palpate the lymph nodes. And then neck, check for webbing of neck. In chest, check for nipple site and whether they are extra nipples, and the shape of chest, respiratory rate, type of breathing, abdomen thoracic or thoraco-abdominal. Babies have abdominal thoracic breathing just like males. Also check for clavicle injury. Then also check abdomen. In abdomen, check for any protuberance. Check protuberance is normal in babies. It is should be present. Then check the umbilicus for its site or its appearance, and check the umbilical cord for its appearance, or any check for any scars, deformity, pigmentation. Then also check in genital area. In the genital area, check gender. Check the check for cryptocordism, and check the thigh area for any muscle atrophy, and feet. And check for an increased distance between first and second toe, increased skin folds, and in genital area also check for inguinal lymph nodes. In the back, check for spina bifida, check for Mongolian spot which is normal, present above the buttocks. It is a normal spot, green spot. Check for perianal deformities, and check for any check for open anal opening should be open. Then primitive reflexes. There are many, but we will do the following 5: glabellar reflex, number 2 rooting reflex, number 3 sucking reflex, number 4 Moro reflex, and number 5 finger grasp reflex. Now we will do the neonatal examination. Suppose this is our neonate. First we will do the inspection. On inspection, we can see a well-looking child who is lying comfortably on bed, on the table, and there is no intervention like cannula or any other device attached to the child, so I will not mention it. And child is well-looking and is responsive, and there are no apparent dysmorphic features or cyanosis. There is no peripheral cyanosis, which is often normally seen in neonates, and it returns to normal after some time. So we have only seen on inspection that the baby is a well-looking child lying comfortably on a table and is responsive. Now we will do the anthropometric measures, but we prefer to do it at the last because this will make the baby cry and will hinder our other examinations. So we will do what we can do, and then we will try to do anthropometric measures in the end. First we will do that, and then we will start the examination, and we will look at the fingers of the baby for any signs of clubbing, Koilonychia, or splinters, or any other peripheral cyanosis or any other deformities. And we will look at the palms for any simian crease. As we all know, in the neonates, or we can easily identify Turner or Down syndrome. Others are difficult to identify, but these two syndromes are easy to identify in neonates. Like in simian, like we can see the simian crease of Down syndrome. Then we will look for the wide wrist if there is any. We will count the digits. They are five, and we will also count the toes. They're also 5 and 5. We will go upward, and we will upward, and then we will palpate the axillary lymph nodes via proper procedure. Then we will go to the head. In the head, we will palpate the head for the anterior fontanelle, and we will check its shape, which is mostly rhomboid, its size, which is mostly 2.5 into 2.5 centimeter. We will check palpate all the sutures, and because also they should be open. They are open, and they are non-fused. And then we will look at the back of the head gently, and we will try to feel the caput here. Caput hematoma that happens in prolonged spontaneous vaginal delivery. And we will then, on lateral sides of both heads, we will try to feel for cephal hematoma, which happens during instrumental vaginal delivery due to instrument application. We will also check the ears inside through torch, and their outside also, if there is any dysmorphic features, low set ears, or any injury due to the instrument. We will also check the other ear, and because it is a pair. Then we look at the eyes. In the eyes, we will check for brush field spots, some conjunctival hemorrhage, jaundice, cataract, epicanthal folds, or wide spaced eyes, or minor spaced eyes. But these are normal eyes. We will check the nasal bridge, it is present. We will at torch we will check the septum of the nose, if it is deviated or any problem or discharge present or not. Then we will check the mouth. We will check the lips for any deformity, cleft lip or cleft palate inside. If there are any teeth present, any neonatal teeth present, which could be present, it is not a special thing. Then we will look at the neck. In the neck, we will check for any webbing of the neck, which happens in Turner syndrome. And we also check the back hairline. If it goes way down, then it is Turner syndrome. Then we will check the chest. First we will check the axillary, the lymph nodes, if possible. All the possible lymph nodes that we could palpate: submandibular, anterior, posterior cervical, occipital, anterior auricular, posterior auricular, from front and back, via front and back procedure. Then we will look at the chest, its shape, the location of nipples, which should mostly be in the mid-clavicular area. If they are wide apart, then could be Turner. Then we will look at the shape of the chest, whether it's excavating or depressed. And then we will look at the respiratory rate and the type of breathing. And in neonates and babies, it should be abdominothoracic. That is a normal breathing. And also in just like males. Then we will look at the abdomen, and abdomen is in neonates is protuberant. If it is not protuberant, then there is problem with the intestine location. Where are they? Whether they're in the chest or somewhere else. Then we'll look at the umbilicus, its location, where it should be central. It would be everted, and with the umbilical cord attached, should be the condition of the umbilical cord, whether it has dried or whether it is fleshy, whether it is pulsating, whatever we see. Then if there are any deformities, any coffee color spots, any pigmentation, any cyanosis. Then we also look at umbilicus, whether it looks like a hernia or a normal averted umbilicus. Then we will go down, and we will see the inguinal lymph nodes. We will palpate the inguinal lymph nodes. Then we will look at the genitalia, and in the genitalia we will look for what is the gender of the baby, and if it's a male baby, then we will check for cryptocortism, whether the testes have descended in both scrotum, and descended in the scrotum. And then we will go down and look at the thigh muscle, because it could be muscle atrophed. We will check. We will look at the thigh muscle folds, whether they are present, whether the thigh muscle is normal. Then we will go down, look at the toes, whether is there there shouldn't be any wide space between first and second toe, which is a sign of down. We will also look for if there is abnormal skin creases in the soles, which is also a sign of down in both toes because it is a pair. So we will compare. Then we will go to the back of the baby, and in the back of the baby we will check for any spina bifida, cystica, occulta, any hair present along the spine, hairy patch present along the spine, and then along the buttocks there should be any perianal, if there is any perianal spots, deformities, anything. And then we will check for the opening of the anal opening. We will check for the anal opening. After that, if there is a greenish colored spot, there could be any greenish colored spot here and there. These are Mongolian spots, which are normal spots. And then we will check for the primitive reflexes. These are done. Now we will check for the first we will do the anthropometric measures, which details are in the next videos. And anthropometric measures of height via infantometer, weight via infant weighing scale, and head circumference and mid upper arm circumference. And then we will plot them in the growth charts. And after that we will do the primitive reflexes. We check the baby for the primitive reflexes. In the primitive reflexes there are many, but the 5 that we will do will be, the one is the glabellar reflex. In the glabellar reflex we will tap the glabella of the baby, and the baby will be annoyed and will close his eyes. Then the other one is the rooting reflex. In the rooting reflex we will tap the angle of the lips, and the baby in a reflex to it thinks that it will be fed in this direction, so it will move its head in this direction. This is the rooting reflex. If we tap near its lips, or we will anything near his mouth, it will feel like it is going to be fed, so it turns its mouth into a sucking position to suck for the nipple, so it is a sucking reflex. Then we will place our finger inside the palm and it will grasp my finger, so it is a finger grasp reflex. And the last one that we will do is the Moro reflex. In the Moro reflex we will take the baby's head a little above, and we will a little bit throw the baby's, or let the baby's head free fall on the other palm, like this. The baby will reflexively first extend his both arms like this, and then it will flex both arms. These two movements is the Moro reflex, extension and flexion, like someone is frightened. And these were the reflexes 5 that we will do. And there's one thing that I have forgotten to mention, that on inspection we have to see whether the baby has flexed all his limbs like this, like a frog. This is normal. This should be present. The baby should be able to flex his limbs. This is normal. And if it is unable and it has extended, then it is abnormal. Thank you.